Good day! For this session, we would be discussing the peripheral blood smear, how to make one, what one expects to see in a peripheral smear, and the red flags that we should be watching out for, which warrants our immediate attention. Now, I see the peripheral blood smear as an important addition, sort of an extension to complete the assessment of a patient, especially for someone who has an abnormality in their complete blood count. Thus, it also means that the peripheral smear does not stand alone. We need to know the patient's history and physical exam, and also the complete blood count, so that we already have an inkling as to what we have to be looking out for in the peripheral smear. Another advantage in doing a peripheral smear for a patient with a suspected blood-related disorder is that it's easy to do, and in a matter of minutes, one could already arrive at a diagnosis. So how do we go about in preparing a peripheral blood smear slide? Well, we can ask our laboratory to prepare the peripheral blood smear slides for us, but it's quite an easy procedure to do, and you can even do it at bedside. So first, prepare your materials. You would need glass slides, at least 2 of them. Then you'd also need cotton, you'd need alcohol, you would need a syringe needle or a lancet. So first, clean the finger that you would be performing your puncture well. So usually we choose the ring finger of the non-dominant hand and try to milk that finger to increase blood in that area. Then with your syringe needle, swiftly pierce the side of the finger. Wipe off the first drop of blood that comes out. Then put a drop of blood on the slides. Using your spreader, pull back a bit. Then push until the end of the slide. Push without hesitation. And we allow these slides to dry. In staining the smear, the slide must be air dried first. And usually the staining solutions are already prepared. So first, we dip the glass slide for 10 seconds in the methanol fixative. Then for around 10 to 15 dips in solution number 2, which contains eosin. Around 15 to 25 dips then in solution 3, which contains methylene blue. And lastly, dip it in solution 4 or phosphate buffer or clean water and allow it to air dry. We examine the stained smear initially under the scanner objective to have an overview of the slide. We try to see, is there a lot of WBCs? Is there clumping? And also to locate which areas we should be focusing on. Then afterwards, we then switch to oil immersion objective to look at the finer details of the individual cells that are in our peripheral smear. So this is an example of a well-made peripheral blood smear slide. The smear occupies half of the slide with a feathery edge. So if we try to examine the peripheral smear at the thick part of it, the cells are going to be overlapping and the morphology of the WBCs are going to be distorted. If we then examine it at the feathery edge, at the end of the feathery edge, while we do get to see the WBCs, their architecture would also appear distorted. However, in those instances wherein patients have a low WBC count, this area would be a good place to look for because the WBCs tend to concentrate at this area. And if we're suspecting WBC abnormalities, such as, for example, in leukemias, we might be able to see it in this area. The ideal area for us to check the morphology of the peripheral blood smear is near the edge of the feathery edge, where under the microscope, the red blood cells appear to be almost touching one another. This and adjacent areas to this would be a good place to identify and study the morphology of the different cells in our peripheral smear. In a peripheral smear, we examine the morphology of the red cells. We also get to see the presence of the different types of white blood cells in their quantity, and also the quantity and morphology of platelets. So this is an example of a normal peripheral blood smear. So mostly what you get to see are red blood cells, which appear as round red cells with a pale center that occupies only 1/3 of the cell. These are the WBCs that we get to see. So first we see neutrophils, which appear as cells with a multilobulated nucleus, usually around 3 to 5 lobes. We also get to see lymphocytes, which appear as small round cells with a really condensed dark nucleus. We also see monocytes, which appear as large cells with an irregular two-folded nucleus. Also, we get to see these small cells, which are platelets. They appear as small dots with some cytoplasmic projections in granules, but they may be hard to see. We expect to see around 15 to 35 platelets per oil immersion field. Eosinophils appear as cells with numerous red granules and also a bilobed nucleus. Basophils, on the other hand, they're quite rare to see because they get destroyed when we prepare the peripheral smear. They have numerous blue granules that obscure the nucleus. Sometimes we get to see some changes in red cells, such as what are featured here. So there are echinocytes, which appear as regular spurs on the membranes of the red cells. And at the other end, we also see stomatocytes, where the areas of central pallor appear as small slits. Now, while they may be associated with disease states, in the absence of clinical symptoms, they may just be artifactual changes. So let's have a look at this particular pathologic smear. Patients with this disease usually are young female with heavy menses, and the CBC would reveal anemia with a low MCV and MCH. Sometimes there is also an increase in platelets as well. Now, taking a look at the smear, we see that the red cells are quite small, smaller than the nucleus of a lymphocyte. And look at the area of central pallor. We see that the entire red cell is almost just central pallor. They're quite pale. This is an example of iron deficiency anemia. Well, not really a red flag as it can easily be managed, but still something that we get to see in practice. Let's now take a look at this case. So patients with this particular disorder can generally be asymptomatic, or sometimes they may exhibit symptoms such as easy fatigability. They may also disclose that they have a family history of anemia, or that they themselves have been diagnosed before with anemia that does not respond to giving iron. So the CBC would show anemia also with a low MCV and MCH, but interestingly, the RBC count appears to be normal to slightly increased. So let's take a look at the peripheral smear. The red cells are also quite pale. They're very pale. And there are numerous cells which have a bullseye appearance, which are called target cells. Also, we get to see when we survey the different red cells, we see poikilocytosis, wherein there is a difference in cell shapes, such as we see spherocytes, we see elliptocytes, and schistocytes. So this particular clinical picture and peripheral blood smear are compatible with thalassemia, which is an inborn disorder of hemoglobin. While this has to be confirmed with electrophoresis, especially when the anemia is not too bad, we generally just monitor the patient. Now, how about for this interesting case? So the peripheral smear shows these ring-like inclusions. Now, especially if the patient has cyclic remittent fever and a recent travel history, this is actually indicative of malaria. So this particular slide shows the ring forms of Plasmodium falciparum with a high level of parasitemia. So definitely a red flag. It is an emergency that you would need to send to the hospital for treatment right away. Now, sometimes patients with malignancies or symptoms of malignancies may also have CBC findings of anemia. So they may have slightly an increase in WBC count and also possibly thrombocytopenia. Now let's take a look at the peripheral smear. We see that there are these cells which are actually nucleated red blood cells, and we know that this is a red cell due to the cytoplasm, which still has hemoglobin. It's still red. But it's weird for a red cell to still have a nucleus outside the bone marrow. We may also see what we call a left shift, wherein we see relatively immature white blood cells that are appearing in the peripheral blood. In this case, we see a metamyelocyte. Now, the red cells also may exhibit a teardrop shape, and this is actually what we call a leukoerythroblastic picture, which we find in bone marrow infiltration, also known as myelophysis. So this is worrisome as it signifies bone marrow infiltration, possibly from malignancy. The immature elements such as the nucleated red cells, the immature white blood cells are being pushed out of the bone marrow. And the red cells appear as teardrops because they are being forced out of the small marrow spaces. And this would warrant attention as it indicates that there is the possibility of advanced malignancy which is infiltrating the bone marrow. So let's take a look at this particular smear. So what is it that you see or what you actually don't see? So there doesn't seem to be any platelets. Remember, platelets, they are these small cells and we're not really seeing any of them here. So together with a CBC showing thrombocytopenia with or without bleeding, usually in young females. So in the absence of other causes of thrombocytopenia, this is an example of immune thrombocytopenia. Now, while minimal decreases in platelet count only warrant observation, however, severe drops in platelet count would really need an intervention. Let's compare it with this particular patient who on CBC also has apparently a low platelet count. Now, sometimes the CBC machine readout might also reveal a slight increase in WBC count. However, when we review the peripheral smear, we see that there are indeed platelets present. It's just that these platelets are clumped together. And that's why the CBC machine does not read this as platelets. It reads this as a WBC. And this is an example of pseudothrombocytopenia. And thus the need to examine a peripheral smear when we are presented with a CBC showing a low platelet count. So a low platelet count, it's not always a real thrombocytopenia. We have to examine whether the platelets are just clumping, which is an apparent form of thrombocytopenia. Now, let's take a look at this particularly exciting case. So the patient is really very toxic, has fever, has sensorial changes, and that CBC reveals anemia, thrombocytopenia, and the markers of hemolysis such as LDH, lactate dehydrogenase, and indirect bilirubin are both increased. Now let's take a look at the peripheral smear. This is actually quite scary. You see that there are destroyed red cells, which you call schistocytes. So they look like fragments of red cells. They are the remnants, and there are also remnants of the red cell membranes that have been destroyed that form small cells called spherocytes. So spherocytes, they are the membranes that are left over from the schistocyte. So it folds upon itself. It becomes a spherocyte. Now, due to the vigorous destruction of red cells, the bone marrow now has to work overtime, and it's trying to release immature red cells. Hence, we also get to see nucleated red cells in this condition. Note also that we're not seeing that many platelets in this particular disease condition. So this combination, anemia, thrombocytopenia, signs of hemolysis on lab tests and peripheral smear, and signs of organ damage in microcirculation such as an increase in creatinine and sensorial changes, highly suggestive of TTP or thrombotic thrombocytopenic purpura, which is an emergent condition as it leads to 90 to 95% mortality without treatment and would warrant immediate intervention. Now, let's take a look at this next slide. Let's compare it with the one that we have seen earlier. So, we still see signs of hemolysis because we're still seeing our schistocytes and some of our spherocytes. So remember, schistocytes, those are the red cell fragments, and what's left of it folds on itself. It becomes a spherocyte, a very small red cell. Now, in a background of a toxic patient bleeding all over, together if the patients are presenting with darkened extremities, darkening of the fingers, darkening of the toes because of venous clots, and also again, findings of having anemia, thrombocytopenia. I mean, have a look at the peripheral smear. You're not seeing platelets again, no? And together with a prolonged prothrombin time, these are suggestive of DIC or disseminated intravascular coagulation. Definitely an emergency, definitely would warrant immediate treatment. So let's take a look at some abnormalities in WBCs or white blood cells. So sometimes we have to take a look at the peripheral smear of a patient with an increased WBC count. So especially if it is neutrophil predominant in the background of sepsis or malignancy, we get to see a lot of neutrophils. Even in the CBC, it would report neutrophilic predominance. So let's take a look at the peripheral smear. So we see a population of white cells that are majorly composed of mature neutrophils. So neutrophils, they are already mature, no? So they're sort of the end stage of the myeloid series. And when we see neutrophils, we know that they are mature cells. So these particular neutrophils, they may have toxic granulations. They have granules in them. And sometimes we may also see vacuoles in their cytoplasm. Now, these are actually just reactive changes. Well, this WBC count may be very high since the WBCs are all mature. We know that these are just reactive and not exactly a malignancy. No, so it's not a bone marrow malignant change, and the treatment for this, it's just treating the underlying cause. Now, contrast it to this particular smear. We were talking earlier about a peripheral smear having an increase in WBC. So this one also has an increase in WBC. However, if we take a look at the white blood cells, we see that they are what we call monotonous. It's because they all look the same. It's like they just came from one particular stem cell that has divided and divided. They all look the same. No? So secondly, we also try to examine the nucleus, and there is a little area of clearing in the nucleus which we call a nucleolus. And the presence of a nucleolus would signify that these WBCs are still immature. Now also, take note, we're not seeing any platelets in this peripheral smear. So usually patients with these conditions may present with symptoms of anemia, they get easy fatigability, they can get fever, they get bleeding. The WBC would show anemia, the CBC would show anemia and thrombocytopenia, and the WBC may be increased, just like in this case. No? So they may be increased. However, in this condition, sometimes the WBCs may also be normal or decreased. But the key here is that they are monotonous. They all look the same and they are immature. They still have a nucleolus. So this is an example of an acute leukemia. So generally, as general practitioners, we don't need to really be familiar with the lineage that it's coming from. But suffice it to say that we should be able to identify the possibility of leukemia given a peripheral blood smear. So this is also another example of acute leukemia. So remember what we were talking about acute leukemias. They are monotonous. They all look the same. Secondly, they are also immature because they still have that nucleolus. No? So again, this is an example of a peripheral smear of a patient with acute leukemia, actually AML or acute myeloid leukemia. This also is an example of a patient with acute leukemia. Now, the cells, as what we mentioned earlier, if it's an acute leukemia, the cells are generally monotonous. They all look the same, and if you examine it quite closely in the microscope, you would still see the presence of a nucleolus. No? So it means they're immature, they're monotonous and immature. So this is also an example of acute leukemia. And this particular type is an acute lymphoid leukemia. But we would need further testing to definitively diagnose this particular condition. Now, again, this is another example of acute leukemia. So generally, they would present with anemia, they get fever, they get bleeding, and usually patients with lymphoid leukemia, they're usually young, but it doesn't mean that older people cannot get ALL, and also sometimes they get lymphadenopathy. So a good examination is always important. Now, let's take a look about this smear. So we see numerous WBCs. So is it monotonous? Well, yes, quite a bit. But if you examine closely, they are actually mature lymphocytes. And why did we say they are mature? It's because they do not have a nucleolus anymore. No? So This particular cells, this smear would show a lot of mature lymphocytes. So this is actually still a leukemia, no? And another key feature here is the presence of these smudge cells, no? So they are broken down basket-like cells which result from the smearing of the peripheral blood smear. So this is actually still a leukemia. This is a chronic leukemia, and we say it's chronic because the cells are already mature. So when it's acute, the cells are still immature. A chronic leukemia, like for example, in this chronic lymphoid leukemia, the cells are already mature. So generally, patients with this condition are older, and their CBC would show marked leukocytosis that is mainly composed of lymphocytes. No? Sometimes they may get a slight anemia, slight thrombocytopenia, especially with higher disease stages, and sometimes they also get splenomegaly. So let's take a look at this particular smear. Again, we're seeing an increase in WBCs. But if we take a look at the peripheral smear, we see that it is not exactly monotonous. We get to see different types of WBCs, and they are mature. Why did we say it's mature? Because they are granulocytes. They are neutrophils. So we see a lot of neutrophils, but we're not just seeing neutrophils exactly. We're also seeing all of the other members of the myeloid series, such as promyelocytes, myelocytes, metamyelocytes, stab cells. So again, agreed, this is a type of chronic leukemia also. This is actually the peripheral smear of a patient with CML or chronic myeloid leukemia. So it's myeloid because we see the neutrophils, we see the myelocytes, metamyelocytes, and we know it's a chronic leukemia because the cells are already maturing and they are in different stages of maturation. Again, as opposed to an acute leukemia wherein you just see them in an immature, monotonous types of cells. So again, an example of a chronic leukemia. So there is an increase in production of WBCs, but they are mature, so they're chronic leukemia. So how about this particular slide from a patient? So we have a patient bleeding and having anemic symptoms. The CBC might show pancytopenia, and when we examine the peripheral smear, so remember one of our tips earlier, if the patient has a low WBC count, we can try to have a look at the feathery edge because that is where the WBCs are concentrated. So just like what we did here. So we're examining at the end of the feathery edge where the WBCs are concentrated. And we get to see, although it might not be that clear, but we get to see some of these cells having rod-type inclusions in the cytoplasm, which we call our rods. So let's have a closer look at this particular cell. And when we examine it closely, we see those rod-like inclusions again, no? Which we call our rods. So a bleeding patient with laboratory parameters indicating disseminated intravascular coagulation. So you get a low platelet, you get hemolysis, you get a prolonged prothrombin time. So together that with our rods, it's very worrisome for acute promyelocytic leukemia or APL. So APL, it is also an emergency as it can lead to catastrophic bleeding and death. Now, sometimes APL or acute promyelocytic leukemia can have sort of a different morphology. The cells of APL might appear to have these bilobe nucleus. So instead of having our rods, sometimes they might appear as cells with a bilobe nucleus. Still, the laboratory parameters such as thrombocytopenia, prolonged prothrombin time, they might still be there. So we should be able to recognize this particular morphology again can lead to catastrophic bleeding and death. And also, how about for this particular smear? So usually we examine this smear. We have a patient who's elderly, complains of back pain. The CBC would show some anemia. The smear would also show that the red cells are arranged as though they are in a stack of coins. No? So this is what we call Rouleaux formation, stack of coins. And that is because there is an increase in plasma proteins and plasma globulin proteins. Thus, since proteins are sticky, it makes the matrix quite sticky. So that's why they get this arrangement. So this is an example of a patient with a gammopathy such as multiple myeloma. In summary, a peripheral smear is an important adjunct in the assessment of patients with abnormalities in CBC. We examine under the microscope oil immersion objective near the end of the feathery edge, where we get to see the different morphologies that we have just seen, which helps us in diagnosing our patients. Well, this discussion is certainly not all-encompassing. I hope that we have gained a bit more confidence in taking a look at peripheral blood smears and would be able to correlate these microscope findings with the patient's clinical picture, all to help expedite our diagnosis and management. And with this, thank you and have a pleasant day.